Good afternoon, everyone. My name is Dante Martino, and I'm a provisional psychologist currently completing my placement at the Mental Health Foundation Australia. I'm honoured to be your host for today's webinar. Before we begin, I'd like to acknowledge the Wurundjeri Woi-wurrung people as the traditional custodians of the land on which I live and work. I pay my deepest respects to their elders, past, present, and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. On behalf of the Mental Health Foundation Australia, I warmly welcome you and thank you for being here for Internal Empathy Recalibration, a novel approach to trauma informed psychotherapy. We're excited to explore this innovative framework together, and we're grateful for your presence and participation. Let's dive in. So firstly, I'd like to invite our presenter, Professor Ajeet Singh. Professor Ajeet Singh is an academic psychiatrist with Healthscope Hospitals and Deakin Medical School. He pioneered Australia's first regional RTMS service, founded the DNA-guided prescribing firm CNS Dose, and authored Empathic Warriors Psychotherapy Approach. With over 150 publications, he remains a full-time clinician focused on scalable, affordable mental health innovations. Ajeet believes second-generation pharmacogenetics and AI-augmented psychotherapy will change care in the coming decade. Positioned at the forefront of these advances, he bridges clinical practice, academic research, and strategic leadership to help reduce the burden of mental illness. Please join me in welcoming Professor Ajeet Singh.
Hello, thanks for making time to join this presentation. And Dante, if you're happy, I'll just launch into the slides.
Absolutely, go ahead.
So just let me know, Dante, you can see the first slide that's on the screen, okay?
Yep.
Yep, terrific. So yeah, basically, thanks for that kind introduction. And for me, basically, it's all about trying to ease human suffering. So that might seem overly simplistic and naive, but as a psychiatrist, I'm mainly confronted with the failures of psychiatry. And what I've tried to do atop working as a clinician is to see if there are ways we can improve talking therapies and tablet therapies. And that's really shaped the innovation aspect of my career. And this first picture is a great lithograph from a World War II surviving artist. And it really just captures, I think, what we all know. Anybody who works in mental health knows the importance of stewarding children's physical and emotional well-being. And really the takeaway message for this is there is real hope. I believe there's a massive healing system in the brain. I call it the grief healing system, that's equal to the task of even the most horrid childhood trauma. And so often I'll see patients who've got a refractory mood disorder driven by horrors and difficulties in childhood, and they feel that there's no hope. And I believe there is immense hope, because I believe an entire system in the brain is there to help us digest traumas, including childhood trauma. And so that's the summary line of today. I'll be going into a fair amount of depth. The slides will be available via a link, and I'm happy I'll share my email address at the end for people who want to reach out. It's a fairly busy talk. I knew that if I was going to claim that I'm developing a new style of therapy, I have to kind of back it up. And so there's a fair bit of jargon, philosophic and even biological psychiatry jargon. You don't have to know it all. The reason I've sort of put it there is so it can stand up scrutiny to the boffins in the psychoanalytic and neuroscience world. I'm sort of one of them, but I still see myself as an outsider. And the outline is really going to be talking about the history of talking therapies, which began very much in the contemporary era with Freud, but then moved on to empirical-based therapies like cognitive behavioral therapy, but then enter medications. And this, we're going to talk a bit about how we went from just an impression and theory to everything being data-driven, and maybe extreme focus on either approach let people down. And then moving in the second part of the talk to concepts, which I've summarized in my therapy book, evolutionary design and the empathic spectrum. I think these are key, simple ways to make sense of what's happening in people and how to adapt a therapy approach to those systems. And the grief healing system, I believe, is the great hope when it comes to trauma therapy. and I'll outline that more. And then I've any kind of style of therapy has to have some acronym. So mine is IER, Internal Empathy Recalibration. It's a fresh take on healing the self relationship, borrowing from past wisdom, but assembling it in, I think, a unique way. And then I'll give some basic takeaways for people to apply, but also how I have a vision. So it's a fine line between a visionary and a madman, and I'm not sure which side of the line I fall on some days, but a pathway of turning these ideas into having a scalable impact on the thousands and millions of people who need therapy but can't access it. So start off by doing a quick rewind into the origins of contemporary psychotherapy, which is Freud, and also the implications for and against the trauma-informed care approach. So everybody would have heard of Sigmund Freud. So as a neurologist, physician / psychiatrist, who really, with Breuer in the start of the late 19th century, started to talk about what was radical concepts then. The radical concept for the time that issues from childhood can still impact how you think, feel, and behave in adulthood. That was a paradigm shift for the era. And even more of a paradigm shift is stuff you're not aware of. Unconscious stuff can affect how you think, feel, and behave. In his era, a lot of emotional distress and trauma manifests through neurological symptoms called hysteria. And often neurologists will see these inexplicable symptoms because it was taboo for people to talk about certain types of trauma. And Freud came up with a system involving trying to interpret things, including clues from dreams or slips of the tongue, to make sense of conflicts, emotional conflicts, that then could alleviate some of these neurological symptoms through cathartic experiences. And he was a prolific academic and very influential. Interestingly, in his era, he needed benefactors to fund his research, and some of the benefactors were from well-to-do but highly traumatized families. And this is quite interesting when exploring some of the critiques of the Freudian approach, which would tend to blame children for having sexualized impulses and seemingly minimize a trauma history. So much so that in the 70s and 80s, a number of books were written, a couple of them there, where people would fight back against the dogma of the Freudian thinking that if children had sexualized thoughts, these were their fantasies and not a disclosure of trauma. Now, it is plausible that some of the benefactors for Freud's research and his cases came from wealthy families where there was abuse in the family. And rather than this creating issues for the families that he was dealing with, there was a tendency by Freud to develop theories without any data around children having their own libidial sexual impulses like the Oedipal or Electra complex to explain it, and minimizing the possibility of childhood trauma, which is something that Freud initially talked about in his writings, but then pivoted away. And so there was this pushback against it, particularly starting in the 70s and 80s. Many clinicians were seeing people talk about child abuse and trauma, and yet everything was disproportionately blamed on the victim through seduction theory. Now, we can't hide from an unwanted truth that there's immense number of people who suffer trauma. In Australia, we've got one of the biggest studies in history, the Australian Childhood Maltreatment Study. And if you're not familiar, just Google up Australian Child Maltreatment Study, and there's a whole website on it summarising their findings. It was a large survey of over 8,000 Australians, ages 16 to 65. For that kind of study, very rigorous protocols were applied, and it was the first large nationally representative sample. And the results are consistent with what clinicians see, but very difficult for us to process. So this slide summarises the findings for people aged 18 or younger, so under 18, the number of people experiencing abuse, various classifications, including physical and sexual abuse. And you can see sexual abuse, it's nearly 29% of and a whole of population sample reporting before 18 experiencing abuse. So this really highlights that maltreatment doesn't have to be physical or sexual, even emotional maltreatment, coercive control, maltreatment. These traumas are very common. And I think that's what we often see in clinical practice. And certainly in refractory mood disorders as a psychiatrist, I'd say about a third of the patients I see, the key driver is unresolved issues from complex childhood trauma patterns. We also know that where there is a history of significant childhood trauma, there is a manifold increased odds of subsequent psychiatric diagnoses, including substance misuse, post-traumatic stress, but even major depression can be overly simplified as a neurochemical condition, which in part it can be, but there's a very powerful trauma pattern that's relevant as well. So again, with this data, we can't keep minimizing the role of trauma, and we can't repeat that Freudian error of minimizing the actual impact of trauma on people's mental health in adulthood. And so this has changed the whole paradigm. This is a 2014 slide from the US administration back in the days when people had more faith in it. And it was really saying, look, we've got to move away from this Freudian primitive sexualized desires ontological theory to realizing and recognizing it's very common and respond appropriately and not re-traumatizing. And this has been the paradigm shift over the last 20 years. I remember 20 years ago, asking for childhood trauma in the developmental history of a psychiatric assessment was a side note. Now, if you don't ask about trauma in a developmental history, it's a failable omission in exams. So there's been a paradigm shift happily towards recognizing the rates of trauma, but I think still at a societal level it's downplayed. And it's a big shift from that Freudian approach that over-dominated psychotherapy for decades. And so kind of they're big words, hyper-ontology. It's really just experience-based, no empirical evidence and theories. So that was the whole Freudian era. This great brain Freud, with his take on the experiences of patients, came up with a theory. And then we've moved to the hyper-empiricism. Everything has to be a double-blind RCT, tablet versus placebo, manualized CBT versus generic supportive care. We've almost gone from one extreme to the other, from no evidence and just the Freudian edicts to, if it hasn't got a meta-analysis of RCTs that are double-blinded, it's snake oil. And so I think what we're seeing now is a shift towards a balance between an evidence-based approach, but also that experiential-based, individualized approach. So I think we're seeing a third shift now, and that's exciting because I think this third shift is a more balanced approach. So if we trace the history, and this is just a very quick walkthrough, it was really empirical psychotherapy, empirical talking therapies really began with the psychiatrist Beck, who started out trying to do a manualized counseling approach to compare to tricyclic antidepressants. And this was the origin of cognitive behavioral therapy, which at the time was radical, a simple, seemingly oversimple approach of challenging automatic anxiogenic or depressive-genic thoughts, cognitions, and then disputing them to break people out of these anxious, depressive ruminations, and very powerfully exposure-based therapies for anxiety disorders, tackling avoidance that perpetuates inappropriate anxiety about scenarios. So this is only in the 60s, you started to get these empirical-based talking therapies that then dominated contemporary psychology and psychotherapy. In fact, traditional analytic approaches were boo-hooed as too vague, and it had to be a CBT or like RCT, empirically demonstratable therapy, to even be valid. So we almost completely threw out psychoanalytic approaches and over-adopted manualized psychological approaches because of empiricism, which had its logic. So too with medications. So the first tricyclic antidepressant, imipramine, came out in the late 50s, and it was the first modern antidepressant, but it had heaps of side effects and was dangerous in overdose. So too the move to the second generation antidepressants, beginning with Prozac. And what this saw is the risk-benefit for trying antidepressants altered. So pre-Prozac, there were real risks with using a tricyclic antidepressants. Those risks dropped with the second generation of antidepressants. So we saw two shifts from the Freudian era to the CBT era and the medication era. And what happened, this is a slide summarizing the changes in care of outpatient depression in the US, a sample of over 20,000 people. And what you can see is from the mid-80s to the mid-2000s, a marked drop-off in the rates of talking therapies. Psychotherapy is a catch-all for CBT and individual therapy, and antidepressant use. And the health economists liked that Prozac was so cheap, particularly when it went generic. So they would also be saying, well, take a medication approach. So we saw a rise of an over-medication approach to emotional distress and a drop-off of psychotherapy approaches. And this was also in the context, as I alluded to, there was almost a worship of randomized controlled trials. But randomized controlled trials have issues. It's not always possible to blind them. It's not always ethical to deprive one limb of the study of a treatment. And they're quite expensive. So it's about $40,000 per recruit now to do a randomized controlled trial for a medication. Often the findings, there are so many inclusion and exclusion criteria. They're not generalizable to the messy cohort we see in reality. And also sometimes there's no long-term data because it takes a lot of money because of the time involved to provide it. So we've gone from everything must be an RCT, CBT therapy or medication, or it doesn't exist at all. And this, I think, got rid of some of the humanistic aspects of therapy, which I think need to come back stronger. And so another way of putting it is the N of one. So we only treat one patient at a time, their unique lived experience, humanized care, personalized care, individualized care, which can be done with genetics like pharmacogenetics, but also that therapeutic encounter. If they feel like it's cookie cutter care, they don't feel heard, it doesn't feel authentic. But then equally, we still have to be percentage tennis players. And I think this is where the meta-analysis of RCTs, empirical studies come in, is you can say, well, look, this type of presentation, this, and this have got good percentage tennis, but I have to map it to the individual. And I think this is what adept clinicians do, but has been not focused on when there's systematized care. And epistemology, which is really the philosophy of seeking truth, you could argue is this hybrid between empiricism, the RCTs, versus ontological approaches, the lived experience, the human experience, the N=1 encounter in clinical care. And there's nothing new under the sun. These ideas of the tension between percentage tennis medicine and the individual, the Canadian physician, from the 19th century, who's still considered one of the gurus, he's quoted as saying, the good physician treats the disease, the great physician treats the patient who has the disease. And it's the same in any care. We map our percentage tennis knowledge, but humanize it to the one. Carl Rogers is still a famous US psychologist in the mid-20th century, really started to emphasize the importance of humanizing things. And a beautiful quote, which I'll read, a Carl Rogers quote, is, when the other person is hurting, confused, troubled, anxious, alienated, terrified, or when he or she is doubtful of self-worth, uncertain as to identity, then understanding is called for. The gentle and sensitive companionship of an empathic stance provides illumination and healing. In such situations, deep understanding is, I believe, the most precious gift one can give to another. And I think experienced clinicians know the truth of this, but it can seem namsy-pamsy. It lacks biological neuroscience, grit, it lacks RCTs. But I actually think what Carl Rogers found does map to very powerful circuits in the brain and can lend itself to empirical valuation. And we can harmonize these approaches, the Feely approach to the data-driven approach. And his idea that empathy, congruence, and unconditional positive regard were keys in the therapeutic encounter. This overlaps with emotionally corrective experience or selective reparenting described by other theorists. And a way of trying to put all these things together, because we know if you're empathic congruent, it does in of itself have a therapeutic benefit. But how does that work and how can we simplify it? Further academics in psychology have very rigorously, Lambert and Norcross are prime examples, have done massive works on common factors in therapy. And, it's amazing. The type of therapy per se seems to only be a subset. So it's really, the secret is the relationship, you could argue. And the biggest component they've found that was identifiable, obviously there's a lot of other factors, life events, things not captured in the study, but the patient-therapist relationship is key. And that's going to that Rogerian approach of a genuine empathic attunement. If that's not there, the type of the therapy doesn't necessarily track. So there's something core about that human relationship, the flavor of it. And again, does this have an underpinning with a neuroscience and an empiricism we can map on? I think it does. This is also work from Norcross. And again, he talks about alliance. So going through all the psychological literature of the empirically based psychological therapies, the outcomes in the real world really depend on alliance and empathy. And so again, it seems that the real juice is not so much how well you've memorized the textbook, but the emotional vibe, the therapeutic relationship. So there is a hard science around this. It's limited, but it does exist. And this is a busy slide, but basically, this is a 2018 review by Marwood, looking at functional MRI studies of various circuits, brain activity changes of psychotherapies of various type, when they work and when they don't work. And interestingly, when people get better, the changes in the brain, particularly the frontolimbic circuits, the anterior cingulate and associated regions in the frontal lobe, have alterations mirroring the changes that are seen when medication has a response on a depressed state. So therapy affects the brain, and the circuits involved are similar to the mood medication-related circuits. Also, a circuit for mentalization or empathizing, so a capacity to recognize I have a mental state, others have a mental state, and to harmonize those two things has a much less well-developed but existing literature of neuroscience, and lo and behold, very similar parts of the brain related to therapy response with psychotherapy or antidepressants are involved. And there seems to be a very powerful network for empathizing and tuning in with people. Again, this is reproduced hard neuroscience. So this idea that the bond in the relationship is a bit airy-fairy is not true at all. It's very powerful circuits in the brain. But again, how can we put it all together to make it simple for patients to understand, and us? And more importantly, to break away from the thinking of the soft skills in therapy to the hard neuroscience, to a harmonization of both, and not necessarily medication on the one side. It could be manualized CBT versus the soft skills like the Rogerian approach. So I think we are moving, I call it an enlightenment, where we're harmonizing between this hyper-ontology, the vibe without evidence, and hyper-empiricism, if there's no RCT, it's snake oil, to a mixture of the two. So I think this is going to be healthier for us as professionals who work in the field, but also for patients to understand things. So now we're kind of moving to what I believe are novel concepts to try and synthesize everything. And the first concept with that background, and it was intense, but I think we needed to have some neuroscience and psychoanalytic intensity in the preamble, is evolutionary design and the empathic spectrum. And so most people will be familiar with John Bowlby, the pioneering researcher, looking at parent-child, and secure attachments in childhood seem to shape patterns in adulthood, whether they were highly avoidant, anxious avoidant, disorganized, or secure attachments. And so one way of making sense of it is the way a child survives is by being securely attached to their tribe. This makes sense. It helps explain separation anxiety. So the way a small person survives is they stick with their tribe. To fight your tribe or leave your tribe was very low odds of survival. And moreover, if you have a toxic tribe, I believe people will twist their view of themselves in the world to harmonize with the tribe. It's almost a bit like Stockholm syndrome. People who might be held hostage by malevolent figures, be it hostage takers or in their own family, if there's toxicity there. And because the brain is not a logic machine, it's a survival machine, one could argue, they'll twist the narrative that everything is their fault, or they have to tolerate abusive dynamics as part of their attachment. And I think the attachment theory of Bowlby also maps to brain pathways and circuits that are very important. And so this is a busy slide, again, apologies, but it highlights the oxytonergic system. So I talk to people about oxytonergic health. So many screen-dependent things. It's dopaminergic hits, likes, views, fear responses. But there's another well-being system, the oxytonergic system, which appears to mediate a lot of the rewards of human attachment, which are key for mother-child bonding, but also group and tribal bonding. And so if you make sense of things through evolutionary design for group survival, we survive by bonding with our tribe and bonding as groups. This is the only way we survive. And it would make sense that there are deep systems in the brain that reward those behaviors. And so very much in very deep parts of the limbic system and mesolimbic system, there's an overlap between dopamine pathways and oxytonergic pathways. And so there is a neurobiology to explain connection to people and why it rewards us. And there's a genetic influence as well. People have different oxytonergic systems, different dopaminergic systems, a different predilection to be their brain lighting up with connection or not. And so if we, again, think at a very high level how to simplify the complex to make sense of things through their design, humans survive by group action. And so if you could bond in groups, in family groups, tribe groups, you could survive. And instead of being trampled by predators or woolly mammoths, you could cohere and survive. And this survival reproduction engineering for evolutionary design, I think, makes a lot of sense. And it makes sense when you think of groups, not individuals. And so I think empathy and remorse, one can argue, are complex traits where there's genetic and environmental factors, and there's a heritability of both. So GWAS just means genome-wide association studies, and they suggest there is a genetic aspect to different capacity to have empathy. So some people have more capacity for empathy than others, and in part this is probably a genetic trait. Also, there are oxytonergic gene variants that mediate how able somebody is to empathize and mentalize. So obviously there are big environmental factors, but to some extent there appears to be a genetic component. And so now there are multiple studies, genetics, imaging, heritability, suggest, callous unemotional traits, a lack of empathy, sociopathic traits are to some extent heritable and contribute to those behaviours. They can never be used as an excuse. People have to have personal behavioural culpability, but it is agreed in the literature that people's capacity for empathy and remorse does vary by traits, probably in part genetic. So this inspired me over a number of years working with patients and working through their trauma to try and simplify how I explain the therapy encounter with them. And this is summarised in my book, which I kind of gently released at the end of last year just to see if it died a death or people kept buying it. And fortunately, the latter is manifest. And so one of the epiphanies I've had, which I believe can help patients, is I tell them about an empathy spectrum. So often patients come to me and they'll feel lost about how they've survived difficulties in their family. And I'll say, look, there's an empathy spectrum. People are different. Some people have an innate capacity to empathize. Others are relatively unempathic. And that unempathic or more narcissistic style parent figure, they might have made a better tank commander. They might have been good if the tribe was dying out. They could go to the neighbouring tribe, steal food, or even attack the other tribe, bring it back to your tribe, and that helped your tribe survive, and they could sleep well at night because they had limited empathy or conscience. So again, it's almost like there's a function in every group. You'll have different immune systems, different blood types, different empathic types. If everybody in the tribe was hyper-empathic, there'd be a survival disadvantage because you wouldn't be able to play hardball when you needed to. Equally, if everybody in the tribe was very unempathic, they'd eat their own. You're not really good at nurturing the creche in the tribe. And so you could argue each tribe has a group of people who have a higher innate empathy through oxytonergic genetics, the circuitries in the mentalizing system. And they tend to be good at nurturing the next generation of the tribe, less good at making brutal warlike decisions for tribal survival. And then people in between, partially empathic. And I tell my patients, look, I think I'm partially empathic. I can empathise, but then I can switch off so I don't burn out as a clinician. If I was overly empathic, I'd burn out very quickly. If I was unempathic, I couldn't connect with patients. And this has a huge amount of valence with patients. The other thing I've found really useful is patients will often say to me, well, I've got multiple brothers and sisters, yet I'm the only one damaged by the emotional harshness of our childhood. We all have the same childhood, but I'm the one most affected. And universally, I'll say to them, who's the most empathic out of your siblings? And they all say me. They are. And so I think the more empathic you are, the more vulnerable you are to empathic injury. And if there are people who've had injuries and emotional problems and they wonder, oh, my siblings aren't affected, it's really useful to point out, were you the most empathic amongst your siblings? And then instead of a blame game, it was my fault or my parents' fault, we can talk about empathic style and there being a mismatch. And then this leads to the other concept I found incredibly useful, empathic acuity. So it's just like megapixels of a camera. If you're a highly empathic person, you can read people in detail. You can sense, they say they're fine, but you sense they're not fine. So you can be like X-ray vision. The child says they're fine at school, but you feel they're not okay. There's an uneasiness. And then you burrow in and maybe there's bullying at school. Whereas if a parent is low empathic acuity, they might be almost colorblind. They might not be overtly harming the child, but the child feels alone. It's almost the parent can't intuit the child's not doing okay. They might report they felt alone growing up. There was no overt mistreatment in childhood, but the parents were on another wavelength. And again, if you were raised in a village setting, you would probably have a multiplicity of parenting figures. Now you might only have one or two at home. So this empathic acuity, if a child has got high empathy, high empathic acuity, they can also conceal their distress. And if the parent's empathic acuity is lower than the child's, they might not even recognize it. So I believe this is another factor, and it's connected to that neurobiology of the oxytocinergic and mentalizing circuits. So ideally, if you're a child, you have a parent figure who's got equal or greater empathic acuity to you, so they can read you when you're hurting and be there for you. If your empathic acuity is much greater than your parents', they might not see that you're in need, and you can camouflage your needs not to add pressure to a family unit where the attachments seem insecure. So I think if you think of all racial groups, if you dial back a few hundred years, all groups, Europe, Africa, Asia, Americas, we lived in villages. And this is like a Fijian village. And it would be, 1 to 200 people. It was village life. Everybody, I suppose, knew everybody's business, which was irritating, but there was a lot of child protection eyes in the village. And also, on a daily, weekly basis, you would interact with multiple parenting figures, the uncle, the aunt, the older cousin. And if somebody didn't have your empathic style out of your mother, father, there'd be an uncle, aunt, an auxiliary parent figure who on a regular basis, you would be on their wavelength, and the child might not feel abnormal or emotionally alone. It might be that they were incompatible with their mother or father, but that older uncle or aunt would just wink and smile at them every other day when they crossed paths in the village. So I think when we were in a village setting, it was probably the setting our brains were designed for emotional well-being in that setting. We've seen civilization progress. Arguably, we're on the precipice of the fourth revolution with AI, but the mechanization of the 18th century was huge. And what this led to was the need for high density housing. So factory workers could be right near the factory. And we killed off the village and the ecosystem of auxiliary parent figures. And the same is seen with the rapid urbanization in Asia. As China and India industrialize at an epic scale, there's also a surge in emotional disorders. And one could argue the sociological factor is urbanization, loss of the village setting, loss of the multiple parenting figures. The less parenting figures you've got, the higher the odds there's an empathic incompatibility. So in the nuclear age, there's only 1 or 2 parents available. The odds of an empathic match between parent and child drop. And I believe this is a sociological driver to a lot of the emotional issues we're seeing currently. And so this empathy spectrum from the perspective of the child is if you have a highly empathic child in a household and there might be a low empathy parents, the child will often feel unlovable, alone, undeserving, insecure. Nobody can read when I'm hurting, I'm by myself. And in the extreme instances, overt child abuse. From the perspective of the parent, they may just feel oblivious or incapable of empathizing with the child. If they have a narcissistic personality style, they may only have capacity to self-empathize, no remorse. So there can never be a family therapy of mending the bridges, because the unempathic narcissistic style family member never owns their bad. And so you have these vicious cycles of, you could have the empathic child in an unempathically parented setting. And this, I think, becomes an engine room for a disordered self-relationship. And with the term narcissist is overused, but where there's a failure in this empathic capacity, it can be overt, but often there'll be the covert presentation. So the patient will have the preferred parent, but then you point out, well, your preferred parent was a bit missing in action, standing up to the harsh dominant parent, and your preferred parent seemed to use you as an emotional crutch in your childhood. And maybe they had a wounded narcissist pattern. So often this framework of understanding can help patients bridge to some quite complex and tricky conflicts that then take them out of the cycle of repetition from unhappy childhood dynamics, where they'd blame themselves for everything, instead of seeing an empathic mismatch between parents and associated conflicts. But this narcissism is more scary because at a cultural level, it seems that the corridors of power now tend to be overpopulated with the narcissistic type persona. And in the malignant form, which seems to be operant in global affairs right now, very toxic outcomes can happen. So in this way, the interpersonal dynamics in the home can translate to the boardroom and the cabinets of countries, and we can see dysfunction written at a social level. And I think this pattern is what we're also seeing now. So again, what I've tried to do is simplify all that complex through evolutionary design, empathic mismatch, these different traits, to understand things and use in a therapy context. So evolutionary design and the grief healing, this is where the hope comes in. So it's all that doom and gloom. There is hope. Now, this is startling statistics. Is infant mortality was very common up until the modern era with antibiotics. I think the statistic is in 1900, at the peak of the British Empire, infant mortality was 15%. So death of a child is a level 1 trauma, and it was common. And if you think about it, if it's common and it's a level 1 trauma, if that resulted in the mourning parent disengaging from life, there would be a survival disadvantage. And so I think all complex animals have a grief process. There's an attachment, so the group coheres, all for one, one for all, oxytocinergic, mentalizing circuits. But when there's a death, there's a period of mourning. And I think that work by Elizabeth Kubler-Ross, is a psychiatrist who pioneered stages of grief, death, and dying and adjusting. These steps, I believe, are very commonly seen in therapy. There'll be shock, denial, anger, plea bargaining, and then a depression resolution and acceptance. And I think there's a neural correlate that's yet to be identified on a fMRI of a grief healing circuit system in the brain. So the grieving elephant, grieving its dead calf, after a period of time, regains her appetites, has a lust for life again, can survive, reproduce. So I think our evolutionary design for group survival, we have a system to bond and love each other and be hurt when we lose somebody, but also a system that can grief heal, and it becomes old news and you move on and live again. And I think that grief healing system is the big hope, because it enables very heavy trauma to be digested. And in a very limited way, only a small number of studies, there appears to be specific circuits involved with reminders of death and loss. So again, there isn't any clear neural circuit that's been identified for grief healing, but I believe there is one. And the good news is that's a powerful system put in there by evolutionary design for survival. And it's as powerful as your brainstem that makes you breathe even when you don't want to. There's a grief healing system if you can access it. So the idea of internal empathy recalibration therapy approach, how do we put it all together into a teleological understanding, understanding things through its purpose? So the human brain is there for survival, and we have develop a grief healing mechanism so that we can overcome hurts and survive and reproduce again. And I think this is the premise for why there is a grief healing mechanism. But trauma is ubiquitous, and there is mechanisms where we disconnect from our own grief healing system. And this underpins the approach to therapy I'm trying to emphasize. So in internal empathy recalibration, explain to patients the idea, and they can read the book. The book's written for a lay audience. It's not written for a technical audience, of how we've survived from group survival. The brain is not a truth machine, it's a survival machine. And we can twist the truth, we can distort our self-narrative to survive within a group. And then modern society is abnormal. We used to have multiple parenting figures, better odds of an empathic match. That's lost. And this approach helps people get an intellectual insight. They're less perplexed about how they are. This already assists them. And then explaining more about the empathy spectrum takes away blame game and instills hope, particularly the grief healing mechanism. And I found that very useful to engage patients. They go, okay, there is hope. I thought my horrid childhood was too horrid to heal from, but it makes sense as a grief healing mechanism for animals to overcome the loss of a calf, humans as well. So this offers hope. And so, it's a big claim, but trying to put together a grand unified theory of this complexity to that simplicity through that grief healing mechanism as part of evolutionary design for group survival. And so, again, just put together this idea. It's similar to healing the self-relationship, humanistic self-psychology, but mapping those two things, evolutionary design for group survival, empathic spectrum, and some of the neurobiology, believe is a fresh aggregation. And so educating patients, an ego-syntotic education, they no longer feel stupid for being an empath, that their siblings were less affected because their siblings were less empathic. There's less of that guilt blame game in families. Parents may have tried their best but were emotionally colorblind, had low empathic acuity. And the hope is there's a grief healing system, the heartache of never having the wholehearted bond with a parent that you yearn for. You can grief heal that and it can become old news. What happens in trauma often is, particularly marked trauma, is people will disconnect from their trauma, dissociate, or invalidate. So if there's trauma so great in childhood, to connect with it would explode your brain and you wouldn't survive, you don't connect. So the patterns I see is people either self-invalidate, my childhood wasn't that bad, I don't have the right to be upset, and or they lack self-empathy, they just dissociate. Because if they connected with their upset, they might have conflict with their family. And again, the brain is there, fight yourself, not your tribe, blend in with the family, even if they're not meeting your emotional or basic safety needs. And then the third layer, the good news, is the grief healing mechanism. And at a very high level, people go from being a harsh, vicious self-coach to a kind self-coach. So I'll often ask patients, can you give empathy to others but not to yourself? And if they say, yes, that's me, I say, look, I think you need internal empathy recalibration. You've probably tuned out of your hurts to survive, to stick with a toxic tribe growing up. And this is essentially the very high level, simple approach. And when people develop that balance of empathy to self and others, they're more able to be kind but self-assertive and go from that cruel self-coach to a kind self-coach, which improves life aspects in every domain, even their engagement with healthcare, finances, as well as emotional well-being and relationships. The timelines vary. So often I'll see patients who've got very severe refractory trauma. They've tried multiple therapies before. And so that can be an 18-month process. The way I work with patients is an intensive therapy, so it tends to be weekly sessions for 6 to 18 months, typically 12 to 18 months. But this is a refractory group. But then accessing a therapist is so hard and expensive. This becomes a roadblock to implementing these forms of therapy. So part hope was the book could help some people who maybe don't need a therapist or are trying to work with a supportive therapist but get some epiphanies. They could use it as a bibliotherapy. And the book is written, pretty much anybody with a primary school education and above can comprehend it. But it's designed to read, and it has case studies in it that can be worked through. And so the takeaways it's a lot to process. And again, happy for you to get the slides from the organisers, have a link, and you can not ring me, but email me direct for the slides as well. But a balance of theory, of empirical, but also the experiential approaches, I think is best care. Evolutionary design for group survival brings a lot of explanatory power. The brain is a survival machine, not a truth machine. So we'll twist the truth about ourselves and our family to blend in. Makes a lot of sense. The nuclearization of families was the real nuclear damage. We lost multiplicity of parenting figures, and then the odds of an empathic match between child and parent figure dropped. And then a model of self-understanding that transcends the blame game and gives hope that a grief healing system, no matter how heinous your child trauma is, there's a system there to digest even the pain of losing a child and move on again. And I think it's a call to action, because I think at a sociological level, we're all seeing what's happening in the world. The corridors of power, it seems the empaths tap out or get bruised out of career progression mid-career. And then by the time people are in their 50s and 60s, it's disproportionately the unempathic types who rule the corporate boards and committees and cabinets of government. So I think this microcosm of dysfunction in the family gets projected to global governance. And that may sound like an overkill, but I believe there's a logical interlocker between those statements. So scaling the impact, obviously, what depresses me is that we need armies of therapists. 1,000 is not enough. We need millions. So scaling the impact, and be I visionary or madman, probably both, but I'm going to have a go. And so book, workshop, and AI is the path I see. So the book's available on Amazon. You don't have to get it, but already I'm seeing patients are reading it, or they're sharing it with loved ones, or somebody will be in therapy and the partner will read the book and know what we're doing in therapy. And I'm finding the feedback very positive at this stage. I haven't done any marketing, just word of mouth in a very limited way, but it is available online. And then I'm thinking moving into next year, because there's been a lot of interest showing, and I'm interested in people reaching out to me from this audience as well, is moving to even doing some workshops around this approach, and even some basic CME creditable training so people can feel emboldened. So you might be a lay counsellor who's wanting more karate, or you might be wanting an extra weapon in your arsenal as an experienced therapist, and having a credentialing can give people confidence to build what I believe is needed as an army of therapists to tackle despair. And then AI is going to be a scary thing. I think where humanity uses AI, it'll be good. Where AI uses humanity, it'll be scary. But it does appear that there may be a future where you can augment humans. So it may be a future where you've got an excellent empathic counsellor, but they're struggling to get epiphanies, breakthroughs with a patient, and an expert system built, for example, on the empathic warriors approach may be able to offer them suggestions. And I think this is a way of scaling up beyond the finite workforce and the cost. And the dream would be you might have a young person in Africa unable to afford a psychiatrist, and they might be able to have an expert system guide them in their own language at their own developmental stage within the context of them having a support worker. So it's a way of scaling the impact. So if you're intrigued, I've left about 10 minutes for questions, but if you're intrigued to know more, follow that intrigue. Don't live life too conservatively. You'll blink and it'll be over, but don't be too reckless either. So if you think, look, this is not for me, good, listen to your true self. If you think, I'm intrigued, consider having a look at the book. There's an e-version for $11, so it's not a money-making machine. And then if you feel called that there may be something in this, email me on that email or contact the organisers, because I am thinking of putting together the first cohort of like a training workshop for people who want to say, yes, I am an internal empathy recalibration IER certified practitioner, and to provide them clinical support and backup. And I'm contemplating, even depending on interest, doing an initial workshop to that end sometime next year, maybe in May. But with that, and with 10 minutes left on the clock, I'll leave over to questions now, if there are any questions.
There Thank you, Professor Singh, for that informative presentation on internal empathy recalibration. And we do have some questions. So I'll just go to the first question, which is, how does internal empathy recalibration differ from traditional trauma-informed approaches in terms of sustaining long-term change in client self-concept and relational capacity?
Yeah, so anybody who says they've reinvented the wheel is either lying or delusional. And so it's essentially many of the ingredients in traditional therapy approaches, even if you use a schema approach, or if you've got a CBT paradigm, an EMDR approach. And so I see it as just an alternate recipe to individualized care. And, it borrows very heavily from the person-centered Rogerian humanistic approach. The difference I see, which I haven't found elsewhere, and I've presented this to psychoanalytic groups as well and asked them to catch me out, is the psychoeducative component, where you can actually tell people there's a part of your brain that was designed to digest unthinkable hurt. That's like the gospel of IER. It's like there's a part of your brain as powerful as your brainstem that can digest hellish traumas. And as therapists, we hear horrors you don't want to repeat. And people often think, I can never recover from my childhood. It was awful. And then, so, well, guess what? There's something in your brain as powerful as your brainstem. You can't hold your breath in suicide. Your brainstem says, no, you're going to breathe. And if you can access that grief healing by ending the self-invalidation or the dissociation. So the answer is it borrows heavily from existing wisdom. There's a repackaging that helps with psychoeducation, and it maps to some neuroscience as well. Is there an RCT on IER? No. It's kind of new, and that's that ontological experiential based. So I think adept clinicians will still use their existing karate because that's what's made them adept. But then they might assimilate a slightly different approach. And there'll be a group of patients who feel stuck where they're open to that idea, concepts of the empathic spectrum, evolutionary design for group survival. The human brain is not a truth system, it's a survival system. It'll twist the truth to survive. So I see it as just a fresh take on the same processes, but my hope is it's actually something that can also be put into a scalable format, not just through teaching, but I've also made sure to retain rights on the system. So if there is a helpful, non-evil form of AI companion, you might have somebody who can afford and access a general support worker who might lack the ability to figure out the patterns. And then you could have an expert system say, well, have you thought about discussing this and this aspect with the patient? And for me, that makes me excited because then instead of having to be that very hard to get into and high price point clinician, a broad church of empathic workers could be empowered. And so it's really, I've built it differently so that I could actually subtract myself out. And I think that's different. I think a lot of people who've built types of therapy have also built their little cult following. My goal is to not do that. So I don't know if that's a part answer to your question.
Thank you for answering that. There's a few more questions. We should have time for a couple more. This one was relating to neurodivergence, which is, I would love to hear Dr. Singh's conceptualization of how neurodivergence fits within his model of assessment and therapy, and if he is willing to speak about that.
Yeah, so that's a great question. So speaking to the patients I see to start with, going from is that they've taught me, is there's a group of patients who seem to have parents who are sort of Asperger's, high functioning ASD. And they would say my parent was always provided, but I felt like they were robotic and I felt alone. So one of the patterns I see is the empath who develops persisting mood disorders, and they describe their childhood, and the parents were great, but the parents probably were on the spectrum, and the child felt alone and abnormal and tried to be like them, and it didn't work. The other extreme is the patient presenting who's on the spectrum with recurrent interpersonal challenges. A very simple thing I've found is them just being aware that they're on the spectrum, which is the last 10 years, it's no longer taboo to talk about it. 10 years ago, it wasn't even in the vernacular, right? And them to be able to say, I'll tell them, like, I remember I once had a patient and they were currently single, miserable. And I said, look, next time in the first and second date, tell them your Asperger's, get them to Google it, and that you're not a cold, arrogant fish. It's just you can't facially show that emotion. That one patient ended up married a year later. So I think it's sort of recognizing to accept yourself as you are, empathic style, or also interpersonal style, where there's an autism spectrum element. And then in terms of a lack of empathy or a lack of remorse, I see those as separate domains. So if somebody's, on the spectrum as a interpersonal awkwardness and a rigidity, I see that as structurally different to these systems, which I believe are universal. So I think there is a universal system there, and also grief healing. So even grief healing, your nature of being ASD and the impacts on adjusting, there's utility there. We also know kids on the spectrum, there might be higher odds of having trauma, even school bullying. And so it can be assimilated into the making sense of, and then an egosyntonic narrative of, oh, I'm not abnormal, I am as I am, and my system's there to survive. Even I would tell people with autism spectrum, I'd say, you are the human supercomputer in the tribe. You are the guy in the tribe who knew every type of mushroom and the 5% not to touch, and the tribe needed you. So you can use that evolutionary design thinking, or even the anxious patient trait anxiety. Say, you are the alarm system for the tribe. The tribe needed you, but your life is a bit difficult. So even thinking of evolutionary design for group survival, why am I this way? Think group survival, and then you go, I was the supercomputer for the tribe. I was the alarm system for the tribe. I was the mercenary for the tribe, the unempathic type. And so this helps then people build a egosyntonic narrative, learn to like themselves.
And just one final question. How can practitioners in human services, such as social workers, check and balance their trauma to provide efficient and non-paradoxical trauma-informed services?
Yeah, so I think the question already shows insight. So part of mentalizing or insight is realizing we all bring our own baggage, conscious and unconscious. So the first step is just to be aware that there might be aspects that distort my interaction with individuals or groups. And so I think that's already a healthy culture. And we never are fully aware. So like I always say, insight is only ever partial. And so I think there's two levels. One level is just checking your own mental state day to day, which we do in transference, countertransference. It's like if I'm not angry, if I'm having a good day, and then suddenly I'm feeling angry at a patient, I'll introduce that in therapy and say, well, I was feeling good today, now I'm feeling angry. I'm wondering if there's a communication at some level. Or equally, if I'm grumpy, I just didn't sleep well, I'll make sure I try and subtract out my irritability that day. So I'll say to the patient, I'm a bit irritable, I didn't sleep well, I'm trying to subtract that out. So that's that transference, countertransference, self-awareness. But then there's also the biases. So I was trained as a Freudian, so I just do Freudian work, or I'm trained in schema or EMDR for everything. So we can have ideological biases, whereas I would say our bias should be the best, most efficient path for the patient's well-being. And so again, you might say, well, look, this is my style, but I think you'd be a better fit for that style, even though I don't like it. I care more about your outcomes. And so, or even like trauma, lived experience, people might go through mental health act and think mental health act is always evil, but also sometimes tough love is a lifesaver. And so we can bring our own trauma biases, and often using that phrase tough love. So even like a lot of us will see people with trauma from the mental health system, and I'll say, look, yes, there is trauma, but gosh, sometimes it's tough love, and balancing that dilemma. So I think you've already started with self-awareness, and then in the peer supervision and group meetings, talk about some of these system issues and our biases towards or against mental health act, or biases towards or against different modes of therapy, and how that might get in the way of optimal patient care.
Thank you, Professor Singh, for answering those questions from our audience and your excellent presentation. Thank you all for being part of today's webinar, Internal Empathy Recalibration, a novel approach to trauma-informed psychotherapy. It's been a privilege to explore this emerging framework with such a thoughtful and engaged audience. On behalf of the Mental Health Foundation Australia, I'd like to extend our deepest gratitude to our presenters, contributors, and of course to each of your time, attention, and commitment to advancing mental health care. We hope today's session sparked new ideas, challenged perspectives, and offered tools you can carry forward in your practice or personal journey. A follow-up email will be sent shortly with resources and a feedback form, and we'd love to hear your thoughts. Until next time, take care, stay curious, and continue the important work of fostering empathy and healing. Goodbye for now.